Shaitanirrajim. Bismillahirrahmanirrahim. Nahmaduhu wa nusalli ala rasulihi al-karim. Amma ba'd, fa'udhu billahi minash shaitanir rajim. Bismillahirrahmanirrahim. How are you, my dear students? Hope you will be fine and doing well. May Allah protect you from all those adverse conditions which are prevailing in our society, in our country. Please protect yourself and your loved ones. अल्लाह ताला आपको हमेशा खुश सलामत रखे, महफूज रखे और आपको हर नागहानी आफत से बचाए रखे. This will be my last lecture in relevance to the condition of small intestine. We have discussed various conditions in our previous two lectures, and in the last lecture we discussed with enterocutaneous fistulas and with different diverticular diseases of the intestine. Today I will be discussing with you the malignant conditions of the small bowel, and later on, if we will have a time, we will also discuss the topic of shortcut syndrome, because after discussing all these conditions you may cross a situation when a surgeon will embark upon the resection of the intestine and resulting into shortcut syndrome. So, what are the neoplasms of the small bowel? First, you should realize that among all malignant conditions, tumors of the small intestine are rare in nature. Why these are rare? Because there is a rapid transit time through small intestine, and small intestine have a very effective immune system, and nature of its contents are more alkaline, which is less conducive to the origin of tumors in the small intestine, and it has a relatively low concentration of bacteria. This is maybe surprising to you, but there is multiplication, but it is rapidly washed out from the intestine. So, presence of mucosal enzymes like hydrolysis, these destroy these bacteria and different carcinogens which are being ingested and residing into the small intestine. There is also a efficient epithelial cellular apoptotic mechanism that serves to eliminate clones or bring genetic mutation. You know that continuous replacing older cells with the new cells is also a protective in nature. So all these 6 conditions result into rare occurrence of tumors of the small intestine. It is mostly manifested in relatively older groups. The age ranges between 50 to 60 years, and among risk factors are the consumption of excessive amount of red meat, and that is in the form of smoked or cured foods. Crohn's disease is also considered to be a predisposing factors for the tumors of the small intestine, and with this celiac disease is also an important risk factor. And hereditary non-polycystic colorectal cancers, these also contribute to the occurrence of tumors in the small intestine. Similarly, familial adenomatous polyposis, they also result into small intestinal tumors, particularly duodenal carcinoma is important in this respect. And the last one is Poor-Jager syndrome. These are also considered to be risk factors for the neoplasm of the small intestine. So symptoms are generally those which are with every condition of the small intestine, but mostly these are asymptomatic, and non-symptomatic they consist of vague abdominal pain like epigastric discomfort, abdominal pain, nausea, vomiting, diarrhea. All these conditions non-specific can be Sometimes these patients present with bleeding like hematochezia or hematomesis. By the way, you know that what is the hematochezia and what is hematomesis. Hematochezia is presence of blood in the stool and hematomesis is the presence of blood in the vomiting. And these tumors can present as a case of obstruction, and the obstruction mechanism of obstruction is because of interceptions, circumferential growth resulting into the obstruction of the lumen of the intestine. It can also result into kinking of the bowel, so leading to the intestinal obstruction. And while intramural growth extension can also having a obstruction in nature. So the most common mode of presentation is crampy abdominal pain, distension, nausea, vomiting. These are the general features of the intestinal obstructions. And the second mode of presentation is hemorrhage, unusual or concealed hemorrhage resulting into anemia in these patients. How can we diagnose these conditions? For the most part, these are asymptomatic. So diagnosis is not a first priority in general surgeon. While you can get help with some serological examination like hydroxy in holistic acid for carcinoma tumors and carcinoma embryonic antigen associated with small intestinal adenocarcinoma is rare, but it can be elevated in presence of liver metastasis. So radiological examination is the foremost among diagnostic workup, that is with some contrast studies, which is bearing follow through, and leading to the ultrasound of the abdomen and reinforced with the CT scan of the abdomen. And some varieties of intestinal tumors angiography can be taken into account in case of these lesions which present as anemia and bleeding episodes. Endoscopy do have a role, but these are mostly important in the upper gut lesions like esophagus, gastric, and duodenum. The rest of the small intestine is difficult to be visualized with endoscopes. They require a long length of these scopes. So last time we discussed the role of capsular endoscopy. They can play their role, but only mucosal lesions are diagnosed with this capsular endoscopy. And large gut is evaluated with colonoscopy. This has a role, but so in the small intestine, it is difficult to be visualized with the endoscope. And in our Pakistan society, this evaluation with endoscopy of the small intestine is very limited. So, as any other neoplasm at any other size, there are two groups of neoplasm. One is benign tumors, the other are malignant tumors, and in the small intestine, adenomas are the most common benign lesions. This consists of adenomas. Adenomas are different varieties like true adenoma, villus adenoma, Brunner's adenoma, depending on their macroscopic and microscopic features. True adenomas, these are associated mostly with the bleeding and obstruction. They are usually seen in the ileum, but majority of them are asymptomatic. So only diagnose perioperatively when you come across or open a case of intestinal obstruction and you come across with the adenomatous lesion. Second variety is villus adenoma. These are mostly present in the duodenum, and on contrast radiography, these give a soap bubble appearance. I have shown some pictures in my previous lectures when we were discussing the different varieties of the investigations. And as these are present in the colon, these does not present as a secretory diarrhea, whereas in colonic villus adenoma, diarrhea is a prominent feature in those conditions. To the tumors of the small intestine, and we are discussing the benign tumors of the small intestine. The foremost among these are leiomyoma, and among benign tumors, there are the most common symptomatic benign lesions, which are usually associated with bleeding, and these are usually diagnosed with the help of angiography. Regarding their location, these are mostly located in the jejunum of the small intestine. And there are two patterns for their growth. One is intramurally, and here they cause small bowel obstruction. And the second is both intramural and extramural with the dumbbell shaped. Some part is intramural and the other part is extramural. Here you can see this picture that this is the extramural presentation of this growth. And second variety is lipoma. This is as compared to leiomyoma, it is present in ileum, and it causes obstruction, and mostly it presents as an intersection, because this is a picture of this lipoma, and this is a film study, and you can see these arrows delineating these benign tumors inside the lemma of the small intestine. This is endoscopic view. This is captured through the capsular endoscopy, and lipoma is present inside the lipoma. This can lead to intersusception. You know what is the intersusception? This is the invagination of one part of small intestine into the other, telescoping of a part of intestine into other part of the intestine. These can also present as a bleeding ulcer inside the lumen. And regarding this is malignant potential, these are usually not in case of lipoma. So discussing these two benign varieties of the small intestine, then we will discuss some malignant counterparts, and among these there are common varieties are adenocarcinoma, carcinoid tumors, lymphoma, and gastrointestinal stromal tumors. You know, these are the salient features in front of you regarding adenocarcinoma. These originate from the epithelial lining of the small gut, and these are present in 35 to 50% of the cases, and mostly these are located in the proximal intestine, and in this duodenum is the most common site of involvement. And second variety is carcinoid, and cells of origin for carcinoid tumors are enterochromorphin cells, and these are present in 20 to 40% of malignant tumors of the small intestine, and the most prevalent site of involvement for these tumors are the ileum, and this is distal ileum. Third variety is lymphoma, and the cells of origin for lymphoma are lymphocytes, and it involves remaining 10 to 15% of the cases of the malignant lesions of the small intestine. Here again, the most common site of involvement is ileum. Fourth type of malignant neoplasm are gastrointestinal stromal tumors, and cells of origin are interstitial cells of caudal, and this variety comprises remaining 10 to 15% of the malignant tumors of the small intestine, and these can be present anywhere, but it is mostly prevalent into the proximal small intestine. Individually discussing these tumors, adenocarcinoma are the most common variety. I have already told you that it is present into 50% of cases of malignant lesions of the small intestine, and it is mostly present in the proximal intestine, where duodenum is the number one site of involvement for these adenocarcinomas. And among inside the duodenum, in 50% of cases, this involves the site of ampulla of water. And And while carcinoid tumors, these originate from the enterocolonial cells or Kaczynski cells, and they can arise anywhere from foregut to hindgut. But preferably they originate in the index, then ileum and rectum. This is a picture. You can see that this is a macroscopic lesions of small intestine. Usually these are yellow in color. The characteristic feature of these carcinoid tumors are that macroscopically they appear yellow in color. These are the lesions. Carcinoid tumors are aggressive in behavior, and among these 3% are metastasized, and ileum lesions are mostly metastasized, while in appendix these are usually solitary in region, and in ileum these are multiple numbers. And the most common site of metastasis for these tumors is liver, and when this metastasis occurs, this is called a syndrome, and this syndrome is comprised of following features, which having episodes of diarrhea, patient feels flushing of the face, patient can present to you with features of hypertension associated with tachycardia, and it can also be accompanied with fibrosis of the endocardium and valves of the right side of the heart. So what is the treatment for these tumors of the small intestine? Benign lesions, all asymptomatic benign tumors should be surgically excised. If facilities are available, they can also be resected endoscopically through small gut root, or when they are located in the distal ileum, they can also be approached with the help of colonoscope. Regarding duodenal tumors, it can also be approached with the endoscopic route, where if they are present as polyps, polypectomy can be done. And while you are removing these lesions, area of 2 centimeters of normal mucosa should be excised with the tumor to get a tumor-free margin. And when they are located at the site of ampulla of water, a Whipple operation is usually done. Regarding treatment of the malignant lesions, while we are dealing with adenocarcinoma, again there is resection and anastomosis of the small intestine is requirement associated with the regional lymphadenectomy with this surgical treatment. And regarding the role of chemotherapy in the small intestine, it usually has no proven efficacy in the adjuvant or palliative treatment for the small intestinal adenocarcinoma. And small intestinal lymphoma for localized segmental lesion, again this is resection anastomosis with removal of adjacent mesentery also. If there is diffuse involvement, then chemotherapy have a good role, but there is no role of radiotherapy in small gut lymphomas. Third variety is carcinoid, and the treatment of carcinoid, again this is a segmental intestinal resection with regional and lymphadenectomy. Mind you that if these lesions are less than 1 centimeter in size, they have very infrequent lymph node metastasis. But if they will be more than 3 centimeter size, 75 to 90% will metastasize to the lymph node. And the interesting feature of carcinoid tumors are that in 30% of cases these are multiple, and hence if these are multiple and proven carcinoid tumors, entire small bowel should be examined prior to the surgery, and the areas are involved should be adequately resected and anastomosis. So in the end, we will discuss short bowel syndrome. We are discussing a small gut resection for the various lesions of the small bowel, which can sometimes result into a phenomenon which is called short bowel syndrome. Before discussing, I will discuss with you the physiology of the jejunum and ileum to understand phenomena of short bowel syndrome. And you know that jejunum has large absorptive surfaces while ileum has less. And jejunum is meant for the absorption of the larger molecules while ileum is having less this capacity, and this is because of tight junction between cells and basement membranes in the jejunum, while it is tighter junction between the cells and the basement membrane in case of ileum. While water absorption is usually less in jejunum, while it is more efficient in the ileum. And in jejunum, carbohydrates, proteins, vitamins are mostly absorbed, and iron is absorbed in the duodenum, while in the distal ileum, bile acids and vitamin B12 are absorbed. With this background, what happens and how short bowel syndrome behaves due to proximal jejunum resection or with the resection in case of small intestine. So, interestingly, while we resect the jejunum, absorption is compensatable, while in the distal ileum, digestion is relatively less affected. So jejunum resection compensates in the absorption capacity of the distal ileum. These are the merits for the jejunal resection, while demerits are that there is uncompensated digestion with its resection, with the jejunal resection, while the demerit for the ileum is that absorption of vitamin B12 and bile salts are affected. And the effects of bile salts malabsorption are that there is malabsorption of the fat, resulting in steatorrhea, which is the presence of the fat in the stools, and there is also loss of fat soluble vitamins. While the demerit of the jejunal resections are there is loss of jejunum, hormones leading to the low biliary and pancreatic secretion, and resulting into high gastrin release, which cause mucosal damage and inactivation of the pancreatic enzymes. Both of these conditions can present as diarrhea. So explanation for diarrhea is that in the jejunal resection it is due to the presence of osmotically large actic solutes load, while in case of ileum it is metabolism of primary bile salts in colon, which leads to secondary bile salts and which block water and electrolyte there, so resulting into the diarrhea. So how can we define this short bowel syndrome? This is clinically defined as malabsorption, having clinical manifestation as diarrhea, steatorrhea, fluid and electrolyte disturbance, and malnutrition due to 50%, at least 50% loss of the fat. So, in accurate measurement, it is the presence of less than 200 centimeters of structural or functional loss of the small intestine. This is a picture which can explain the results of short syndrome. Or any underlying disease which result in extensive bowel resection, resulting into the disturbance of normal intestinal physiology, with alteration of the intestinal digestion and absorption, resulting into nutritional, metabolic, and infection consequences. So, what is the pathophysiology of this short bowel syndrome? If there is loss of ileocecal valve, meaning that there is a section involving distal ileum, transit time gets faster from the small intestine into the large intestine, and there is loss of the fluid and nutrients. Fluid and nutrients is greater, while colonic bacteria colonize the small bowel, worsening diarrhea and nutrient loss. While preservation of the colon having merits of colonic water absorption could be increased to as much as 5 times if normal capacity forms from the section. So colon can help for the absorption of the fluid and electrolytes from there. The merits are that there is increased incidence of urinary calcium oxalate stone formation, because oxalate is normally bound by the calcium in the small bowel and thus is insoluble when it reaches the colon. After massive enterectomy, much of this calcium is bound by free intraluminal fats. While colonic bacteria, which metabolize undigested carbohydrates, starch, fibers into the short chain fatty acids such as butyrate, aminate and acetate, so having a disadvantages of remaining colon inside the body of the patient. While demerits are that small intestine gets over-colonized with the colonic bacteria there. So it is physiologically it is defined as, or anatomically it is defined as when the patient is having a presence of less than 2 centimeters of very small bowel, it can result into short bowel syndrome. And while fractional definition for is based as there is insufficient intestinal capacity, resulting in the clinical manifestation of diarrhea, dehydration, and malnutrition. So, what is the length to be defined as short bowel syndrome? In the neonates, it should be 250 centimeter. In the adult, average length is 600 centimeter. Range is 260 to 800 centimeter. So, lifelong TPN is usually required, and for this, in the adults, if there is intact colon, 60 centimeter of small intestine is adjusted with the total parenteral nutrition, and without colon, 100 centimeter of the small gut is required. While in the infant with intact ileocecal file, smaller length up to 11 centimeter of small gut can be tolerated with the total parenteral nutrition. As a consequence, the infant and the young child have favorable long-term prognosis compared to adult individual in potential growth after the intestinal resection. So, we can classify short bowel syndrome into structural versus and functional. And structural, it is when in the adult there is less than 200 centimeter or loss of more than 50% of viable small bowel. There is increased risk of developing short bowel syndrome. While functionally length may be maintained but function is lost. For example, if patient is having radiation intritus or colorectal extrophy, so even a greater length can result into short bowel syndrome. For these predisposing factors are important, while What are the pre-morbid length of small bowel segments of intestine, that is like whether jejunum, duodenum or ileum is resected. So among adults, acute mesenteric ischemia, malignancy, and colon disease usually results in the massive resection of the small intestine, so resulting in Short-Bowel syndrome. And while in the pediatric groups, it is intestinal atresia, volvulus of the small intestine, and necrotizing enterocolitis, which usually result into the Short-Bowel syndrome. What will be the management of this Short-Bowel syndrome? It comprises of both medical part and the surgical part. In medical therapy, H2 receptor antagonists usually prescribed to reduce the gastric secretions with the addition of anti-motility agents like loperamide and with octreotide to reduce the volume of gastrointestinal secretion with correction of the fluid and electrolyte imbalance due to the severe diarrhea, accompanied with total parenteral nutrition or enteral nutrition, depending on the condition. The complication of TPNs are there is catheter sepsis, venous thrombosis, liver and kidney failure, post-uterosis. This is the algorithm regarding the nutritional management in these cases. While surgical therapy up till now, this is non-transplant goal is to increase nutrient and fluid absorption by either slowing intestine transit or increasing intestinal length. What procedures are required for the slow intestine transit? This is a few procedures: segmental reversal of the small intestine, in which a portion is reversed, portion of the remaining small intestine is reversed. Distal part is anastomosis, which is reversed, and the distal part is turned around and anastomosis with the proximal part of the small intestine. Sometimes interposition of a segment of colon between the remaining part of the small intestine, or the construction of the small intestine in valves in the form of ileocecal valves, or electric pacing of the small intestine. With these are having on a limited case report. To slow the transit time, I have discussed with you the few procedures, and these also involve to increase the cut length or area of the remaining portion of the small intestine. This is a picture in front of you. It is difficult for you to understand these, but this picture to some extent explains these procedures. It is beyond your capacity, so leave it. And with failure of these procedures, some surgeons also think of this intestinal transplantation. Indication for this intestinal transplantation is that life-threatening complication due to intestinal failure or long-term TPN with impending or overt liver failure, thrombosis of major central veins, frequent episodes of catheter sepsis, frequent episodes of dehydration. But until now, no success has been reported with this intestinal transplantation. With this, I will end my presentation. Hope you will be fine. अल्लाह ताला आपको अपनी हिफ्ज़ मान के रखे, आपके और आपके घर वालों को और हर तरह के नागहानी आफत से महफूज रखें। अल्लाह हाफ़िज़। लो जी।